Banai is formed and runs under the guidance and chairmanship of Dr. E. Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Avinash D'Souza as the moderator for today's webinar. Thank you, Dr. Avinash, for accepting to be the moderator for the webinar. Dr. Avinash D'Souza is a consultant psychiatrist and founder trustee of D'Souza Foundation, Mumbai. He is the Honorary Secretary General of Indian Association of Private Psychiatry. Dr. Avinash D'Souza has over 750 publications in national and international journals. He is the editor, Indian Journal of Mental Health and Annals of Indian Psychiatry, and is the associate editor, Industrial Psychiatry Journal and Global Bioethics Inquiry. Dr. Avinash is also an assistant editor, Indian Journal of Psychiatry. I would now request Dr. Avinash D'Souza to take over and start the session proceedings. Over to you, Dr. Avinash D'Souza.
Uh, Good evening, everyone, and it's an absolute pleasure to be here for today's topic because the topic is very relevant clinically, scientifically, and neurobiologically. We are in an era of pharmacogenetics and precision psychiatry when it comes to various disorders. We are now going to soon have treatments which are tailor made and individualized to suit the patient. And we have two stellar speakers with us here today because we're going to have two talks on precision psychiatry, particularly in mood disorders and mood regulation. So we will have our first speaker who's going to speak to us on precision psychiatry in major depressive disorder, which is Dr. Debashish Ray. He's a senior consultant psychiatrist associated with MedStar Clinics, Apollo Gleneagles Clinics, AMRI, Apollo Clinic and Hospital, and the Ruby General Hospital, Calcutta. He's a member of the International Research Committee of the International Society of Bipolar Disorders and a founder member of the Society for Bipolar Disorders India. He's had several national, international publications and presentations and chaired multiple scientific sessions in India and abroad. Our next speaker is going to speak to us today about precision medicine in bipolar disorder. And he's Dr. Ranjan Bhattacharya, who's the associate professor and head of the Department of Psychiatry at the Murshidabad Medical College and Hospital. He's also the director of the Charak Square Diagnostic and Research Center. His areas of interest include addiction psychiatry, sexual medicine, and child and adolescent psychiatry. He has 52 publications in various areas. He's the winner of multiple awards and fellowships, the IJCM Award, the BPSSJ Award, the Dr. R.N. Murthy National Award in the field of psychiatry. And he's, of course, a very well-known face when it comes to, I would say, West Bengal psychiatry and Indian psychiatry. So there's no doubt on that. What's very interesting and important is that all of you will have to keep posting your questions in the comment box. I will take them up in the moderation session. Both our speakers, first Dr. Ray and Dr. Ranjan, will speak one after the other. I will not interrupt in between because depression and bipolar are interlinked, so let that go in flow. Post that, I will be there for the moderation of the question answer session. And the best question wins an Amazon voucher of rupees 5,000. The winner will be announced at the end of the program today based on the questions that you all ask. So without further ado, I wish our speakers best of luck and I hand over the mic to Dr. Debashish Ray to start proceedings.
Thanks very much, Dr. D'Souza, for an excellent introduction. Good evening, everyone. I would like to share my slides. What I'm supposed to speak is about, precision psychiatry in major depressive disorder. So, I faced a patient that day, a couple of days back, around 60-ish, 56 to 60-year-old patient who came to my clinic and asked me, Doc, give me the best antidepressant that you have. Give me the best antidepressant for me. I don't want to sleep. I want to be active throughout the day, and I don't want to gain weight. So I was thinking in terms of bupropion. Then suddenly he said that, Doc, what happens is there are times when I have problems in sleeping, and I have also a family history of seizure disorders. So I thought away from bupropion. I was thinking of Dr. Avinash D'Souza, whether I'm going to channelize the patient to him. Then I was thinking in terms of citalopram and escitalopram. The patient continued. There's something else I forgot to tell you. I had a a myocardial infarction, and my ECG is still erratic. It still has my cardiologist tells me that it is still having some issues. It's not at all completely normal, and I'm on 75 milligrams of clopidogrel. This took me again away from citalopram and escitalopram. I was thinking in terms of fluoxetine, but then with clopidogrel, um, the interaction via CYP2C19, which fluoxetine would definitely reduce the bioavailability of clopidogrel. I was thinking in terms of sertraline, and I don't know what I would be, maybe vortioxetine, but okay. So this is what I would be understanding of precision psychiatry in Indian practice today. This precision psychiatry, let's go through a video.
Hi, my name is Alana Simon.
I hope this is audible.
I'm 19 years old and currently studying computer science at Harvard. When I was 12 years old, I was diagnosed with a rare pediatric liver cancer called fibrolamellar hepatocellular carcinoma. Thanks to incredible technological advances, the help of scientists, and the fibrolamellar community, I was able to identify the change in the DNA that leads to this cancer. Rather than trying to broadly learn about all liver cancers, I just examined a small, well-defined patient group, which is what allowed for such a precise discovery. With this knowledge, we're now working on developing the first diagnostic tests and new treatments for fibrolamellar. Last year, at the White House Science Fair, I met the president and got to discuss my research with him. It was such an honor to meet him then, and so it is with great pleasure that I introduce the president to you today.
Well, thank you so much, Alana, for that wonderful introduction. Let me just be clear. When I was 19, I was not doing genetic testing.
Hi, my name is Alana Simon. I'm 19 years.
So this was this is how precision medicine had gained momentum with Barack Obama, who had started this project of a very large population to be studied for precision medicine. And from precision medicine, we are today discussing about precision psychiatry. The father, in fact, of precision psychiatry is someone called Archibald Harrod, who actually innovated almost some targeted treatments concerning alkaptonuria. I'm not going to details about that. So this is how it has been defined by the National Institute of Health. It's basically an ornamental definition, a triumvirate of genetic individuality with environment and lifestyle. So what do we have? Where is this paradigm shift that we are talking in terms of precision medicine or precision psychiatry? What we had yesterday was symptom-based medicine or symptom-based psychiatry, which was primarily intuition-based. We still have a lot of our practitioners, practicing psychopharmacology empirically. From there, we come to today, which is basically a cohort-based analysis of symptoms, a cohort-based analysis of, diagnostic indicators, assisted by what we call EBM or evidence-based medicine. From here, we have to proceed to tomorrow because of today's inaccuracy that we have in our practice. So what we have over here is an algorithm-based practice, and that is precision medicine. How does this precision medicine come about? Initially, what happens is, there are personal molecular profiles which have been sketched with molecular imaging of that person, which in turn gives rise to, a marriage of reference databases and big data analytics. All of you must be knowing about this concept of the big data. We still do not know how big this big data is. However, this big data analytics with a reference databases go through our mobile communications and other communication technologies, and finally give rise to precision medicine, which deals with a more, I would say, classified, a more exact approach to prevent, to diagnose, and to treat any disorder in a subpopulation, as against personalized medicine, which is supposed to be individualized. A lot of people say that personalized medicine is an older term, for precision medicine, and precision medicine is a functionally better term. So this is basically the spectrum of various medicines that we have. I'm not going to go into details about this. And one of the things which brings us today, this evening, about discussing about precision psychiatry in depression is a massive amount of our population, not only 30%, maybe more, textbooks say 30%, are partially responsive to our conventional or the available antidepressant treatments. But a guy like Henry Nasrallah, he thinks otherwise. He feels there is nothing called treatment resistant depression. There's nothing called TRD. Why? Because a lot of these TRDs respond very promptly to ketamine, agents like ketamine, agents like anti-inflammatory medicines. A lot of these TRDs, he says, is a conglomeration of various types of depression, all in one. Iatrogenic depression, maybe because of drug-induced, plus depression secondary to substance use disorders, sometimes depression secondary to general medical conditions like carcinoma of pancreas. Again, most important in this construct that has been offered by him is that major depressive disorder is actually major depressive disorders, and it's a collection of syndromes of multiple biotypes, primarily 4 biotypes. Again, patients with TRD respond to a lot of so-called unusual agents like bupropion. I don't know whether anyone has used bupropion in treatment-resistant depression here. They respond adequately and promptly to neurostimulation like VNS and RTMS. NMDA antagonists, again, they have a dramatic response, not only over the depression of these TRDs, but they also very rapidly reverse the suicidal ideation that these TRD patients have. So when Nasrallah was actually alluding to the biotypes of depression, we have, there are 4 biotypes which have been identified with a common phenotype, with a commonality between them. That is an altered connectivity, primarily in the default, what is called the default network. And biotypes 1 and 2 are highest in energy and fatigue, reduction in anterior cingulate and orbitofrontal cortex. Biotypes 3 and 4, they have high anhedonia and psychomotor slowing. Dr. Bhattacharya Ranjan had very recently talked so eloquently about anhedonia. Biotypes 1 and 4 has, they are very high in anxiety, and they have an abnormal frontoamygdala connectivity. So these are about the biotypes that we have. Now, what is wrong with our guidelines? Why are we talking in terms of precision psychiatry if we have so many of guidelines, NICE, etc., NICE, APA, all of these? The guidelines, what they do, they tell us more about what not to do, how to play safe, instead of telling us what to do. They tell us what not to prescribe than to telling us what to prescribe. And most of them are, they share the so-called criminality over advocating the use of SSRIs. Where does this leave us? We are again back to yesterday, to empirically choose between either the evidence base and experience base, something which has been an old hat these days. My patient asked me, give me the best antidepressant. Do any one of you know which is the best antidepressant for your patient? I do not know. So there was a study, there was a meta-analysis concerning of 12 antidepressants, which showed that efficacy-wise, mirtazapine, escitalopram, venlafaxine, sertraline were the best, and acceptability-wise, side effects otherwise, escitalopram and sertraline were the best, as you can see in this cartoon. In fact, reboxetine has been touted to be the most ineffective of the antidepressants in this study. But we know when reboxetine was available in India, a significant amount of subpopulation of depressive patients, maybe around 5% of our, I would say, metropolis depressive would perform magnificently with reboxetine monotherapy. So where do we go from here? Again, all of you have been knowing about this winter depression, which is characterized with what was called the latent paralysis, evening worsening, hyperphagia, primarily, found primarily in ladies, with a hyperphagia during the evenings, which was initially described, if I'm correct, in 1989 in the Scientific American, coined as the atypical depression by Nies Robinson et al. What is the treatment? The accepted treatment till today is light therapy. Why not an antidepressant? So this brings us, that had actually prompted an Australian group, which also included Michael Burke. I'm grateful to him for this slide. To ponder about a subpopulation of depression, that is, some depressions are actually immunometabolic disorders, like some of the cardiometabolic disorders with a neuropsychiatric or neurobehavioral manifestation. What is the neural substrate to support this? High interleukin K. Look at the tumor necrosis factor in the CSFs. And this itself, they have propounded a 5-step therapeutic protocol to address this type of depression, which also includes what they have been calling inflammatory depression. Mind you, there have been a lot of depressions which were actually responsive maximally to the COX-2 inhibitor celecoxib. So where do we go from here? How do we do this? We don't have any tools right now. One of the things what we can operationalize in a practice is take care of the past response of the patient. If the patient isn't drug naive, the past response to any other antidepressant, that helps us. If that is not present, what the family had responded, primarily the first degree relatives of the patient, what they had responded well, which antidepressant they had responded well. Coupled with this, the interactions, both pharmacokinetics and pharmacodynamic, and possibly also some pharmacodynamic profile of the patient or the subpopulation of these patients. This is something which is, pertinent across races. They have a sub-racial specificity. What is true in the Caucasian population in Italy may not be true in the rural population in India, and so forth. Finally, we have the medical comorbidity. So even without any machine learning, as if, I don't know Python yet completely, even without any machine learning, with whatever psychiatric knowledge, the basic psychiatric knowledge we have, we probably can start practicing precision psychiatry in MDD right from tomorrow. Then this is something which precision psychiatry does pay a lot of attention to. Relationship and specific relationships, sometimes a differential relationship between some symptoms and biological mechanisms. One biological mechanism may give rise to a subset of symptoms. a number of biological mechanisms may give rise to one single symptom at any point of time in the patient's MDD career, if we can use that term. So how does precision medicine help in psychopharmacology? Does it actually help? We have these omics, all these genomics, transcriptomes, proteome, etc., that an individual person has, or the population collection, a small population collection has. We tag them with the personal factors like age, sex, ethnicity, any comorbidity, family history of depressive disorders, tag them with the external environmental stressors, tag them with nutrition, lifestyle changes, past treatment adherence, etc. Then we formulate a decision maker algorithm. From this decision algorithm, the prescriber issues the prescription. What does this prescription contain? How is it different from our run-of-the-mill prescription? This is basically a pharmacogenomics guided prescription, as I was telling, the omic factors, with these personal and environmental factors. So this pharmacogenomics guided prescription helps us not only to increase the efficacy of a particular molecule or molecules, but also to reduce the toxicity. This is why precision psychiatry is very much important in today's psychopharmacotherapy. There have been a lot of these guidelines. One of the important ones is this CPIC guideline. There's also an Oxford guideline. So I'm not going into details into that. There are also pharmacogenetic decision support tools that we have. India, unfortunately, had one tool. I do not know whether they still have it. This was probably in Bangalore. This has been withdrawn. Whereas United States has 19 pharmacogenetic tools at its disposal. In 2017, Roche came with something called the Ampli chip. I was disqualified to participate in this study as I was not a US citizen then. And I don't know about anyone who is a non-US citizen who had participated in the initial study. I have some materials of this, anyone interested. This has been really one of the, the first steps concerning psychopharmacogenomics in psychopharmacology. It came around 2016, 2017, and I was introduced to it in 2017. So we have these pharmacogenetic decision supporting tools like the Ampli chip. So how would we employ this into our patients? The Mumbai patients, the Bangalore patients, the Calcutta patients. We'll have to ask ourselves whether our patients are phenotypically similar to the patients that those tools have been studied. Mind you, in the Caucasian studies, most of the Caucasian studies, 40% of the sample size is females. And 70% of these females are 40 plus. Is your patient population similar to this? Again, does this tool have a good benefit harm ratio? Do we have another tool which you can tease out by machine learning, which can be better than this tool for your patients? And most importantly, in the Indian context, are the patient's values and circumstances, respected when you're using these pharmacogenetic tools? This is a very controversial aspect, the last one. Concerning precision psychiatry, we can differentiate between major depressive disorder, which is a syndromal disorder, from the subsyndromal depressive symptoms by 3 of the 4 co-regulated genes, CTNS. As you see, this one is the subsyndromal depressive symptom. This is the major depressive disorder, and this is the healthy control. So these are the 4 co-regulated genes which are implicated, of the 48 genes which are implicated in major depressive disorders, of which SRTN is also known in case of cystosis. So this actually is actually, almost tempting a lot of these depression researchers to find some sort of a phenotypic similarity between major depressive disorder, at least this subpopulation, with cystosis. So the ADA study, again, another precision psychiatry in MDD, which probably helps us to find out about the neurocognitive predictors of relapse. What did they find? Relapse was higher in depressive patients who were treated by non-psychiatrists. Relapse was higher when psychological factors like brooding, rumination, and neuroticism was there. Relapse was higher when para-treatment EEG, not pre-treatment. I'm using this for a different purpose. You'll understand this as my lecture proceeds. Where there's an alpha symmetry in the EEG while the patient is on an antidepressant treatment. So this is quite eye-opening for any of the run-of-the-mill office practitioner of major depressive disorder. Another study is this PREDICT study, which is still underway. It has one of the highest population size. It's basically an RCD, 913 patients from out of all Europe. It's basically a European study, not yet published. So they were divided into two arms. One is this PREDICT algorithm. This algorithm which was framed by the symptom profile and the lifestyle of the patients. And the other was the usual treatment, what was called the treatment as usual. The primary outcome was a depression rating scale less than 50% at, say, 2 months. The secondary outcome was a reduction in anxiety scale at 2 months and depression at the end of 1 year. There was no difference so far, and as the study is not yet complete, there's no difference, has been no significant statistically significant difference has been found in the primary outcome yet, but already there have been statistically significant benefits in terms of generalized anxiety scores at week 8 and other parameters of secondary outcome, including depression, in this population who have been into this PREDICT algorithm arm. This is another, I was talking about during treatment EEG. We have this pre-treatment EEG, which can probably predict response to an SSRIs. And this has been true for both the sexes. What has been found is we have this, when the EEG finally wanes off, we have this wavelets. The wavelet coefficients which were extracted from the frontal and temporal lobes. You see, even in this is the females, these are the males. Look at the, this is when the eyes are open and this is when the eyes are closed. Look at the response and look at the temporal lobe. The temporal lobe involvement, the frontal and temporal lobe pre-EEG data, primarily concerning the delta and the theta waves, sometimes predict a positive outcome to SSRIs. Now, which SSRIs is still not specified. There's another model like this in precision psychiatry concerning treatment-resistant depression. What was found out is that during the first 2 weeks of treatment, if there has been an adequate treatment response to whatever antidepressant the patient was, the chances of TRD would be less. On the contrary, during the first 2 weeks of treatment, TRD, the possibility of TRD correlated positively with the severity of depressive disorder during the first 2 weeks of treatment, even after the start of the antidepressant treatment. This is another hi-fi thing about, they're trying to tease out hippocampal subfields with the glucocorticoid methylation. So summarizing, precision psychiatry, MDD, probably suggests that we are dealing with major depressive disorders and not major depressive disorder. It may not be just a heterogeneous group of disorders. It may be a lot of subgroups, maybe a subsets of subgroups. We were talking in terms of the omic construct. There may be various omics in this MDD. When we are talking in terms of precision psychiatry in MDD, we have to have the locus properly identified. Not the individual patient sometimes, an individual subpopulation with similar omics, with similar lifestyle, maybe with sort of a similar environmental habitat, milieu. Focus. The focus of the treatment will vary with the same individual at various stages of the depression treatment, at various stages of his improvement during the depression treatment, and if he's a relapsing depressive at various, I would say the first episode focus would be different from the third episode focus, and understandably so. Again, the modus is going to be determined by the specific locus at that point in time and the specific focus or the specific foci in that point of time. So machine learning, as you have said, have a predictive, preventive, and at least therapeutic validity, if not more. And we have to think not only beyond the amines, but also the glutamates. We have been using mifepristone in some of the depressions in women. We have used celecoxib as antidepressants. People have started using bupropion as an antidepressant. So there's a bridge that we have to go to. Maybe far from us, but it is eminently reachable. Finally, we have to use this precision psychiatry in MDD with caution. It should never be, it should never transgress its ethical boundaries. Thank you very much.
Thank you so much. I suppose that I should proceed straight away. Thank you very much. My previous speaker, Dr. Debashish Rai, the versatile, unparalleled genius, sesquipedalian, limpid man with perspicacity, has spoken so well about the precision psychiatry in the depression. It's my pleasure to the chair to acknowledge the moderator of this session, my beloved brother, Dr. Avinash D'Souza, who is highly respectable, adorable, and lovable, honorable mastermind in Indian psychiatry. So let me share my slide first. Am I audible and visible? And my slides are visible?
Yes, sir.
Yeah, thank you. So at the outset, I would like to give my sincere regards and respect. It's a really privilege and honor to Banai for giving me this opportunity to talk in this on this platform and to speak about the precision psychiatry on the bipolar disorder. So we all know that the epidemiology, the nosological concept, and the various comorbid factors have to be considered when we will be treating a patient suffering from the bipolar disorder. And what is precision psychiatry is all about is already mentioned by my previous speaker. Down the lane, around 6 years back, President Barack Obama, in his maiden speech, described about the importance of the precision medicine in general and precision psychiatry in particular. So at the outset, I'd like to acknowledge that there is no conflicts of interest in my presentation. I have not been sponsored by any pharmaceutical houses. There is no conflicts of interest, no competing interest, and the presentation and the slides are being shared, that is by my own, available from the internet references. So we all know about the trajectory of the bipolar disorder. There are elevated irritable mood and other core symptoms of the mania. I'd like to just elaborate here that as you all know about the bipolar 1, bipolar 2, cyclothymia, bipolar nose, the traditional nosology, and DSM-5 is on the book, and very soon the ICD-11 is going to be hit in the market in the month of November 2021. Traditionally, till date, we know that a bipolar 1, which is previously termed as a manic depressive psychosis, being defined as at least one lifetime manic or mixed episode. The diagnostic criteria specified that the mania must last at least 1 week or require hospitalization, and manic symptoms include irritability or euphoria, along with symptoms like decreased need for the sleep, grandiose ideas, impulsivity, increased talkativeness, racing thoughts, flights of ideas, increased activity, psychomotor activities like that. And bipolar 2 disorder is being defined as the one lifetime hypomanic episode, along with at least one episode of the major depressive disorder. Hypomania is characterized by the same symptoms as mania, but it lasts for the shorter intervals, and although noticeable by others, it's not associated with a functional impairment. And we also are familiar with other terminologies like the dysthymia and the cyclothymia. And traditionally, we used to know that this is a common treatment approach with the pharmacotherapy, non-pharmacological therapy, psychotherapy, and other biological therapy apart from the pharmacotherapy in the form of DCT, RTMS, VNS, phototherapy. With this background, I will go with my presentation. I will start with my presentation with the precision medicine and psychiatry. I will go with the artificial intelligence and precision psychiatry. It will take around 5 minutes. I will elaborate about the various domains related to the precision psychiatry, and I will highlight about the metabolomics, particularly about the other omics, and the mathematical model and the new armamentarium in our hand when we will consider about the pharmacotherapy. So already been described that the precision medicine is an emerging approach for the treatment and prevention that takes into account each person's variability in genes, environment, and the lifestyle. So in broad sense, the precision psychiatry has been coined and has been termed by the father of the precision medicine, already mentioned by the Ashley Herald, and it comes with the concept of the dealing with the management of the alkaptinuria. And with day as the day progresses, and we have come with the last 6 years the development of the precision psychiatry with all other factors to be considered. We used to be taught about the biopsychosocial model, then coming to the biological, emphasized with the biological model in particular, with the age, consideration of the age, gender, the ethnicity, the genetic loading, genetic breakdown, already upbringing, two heat hypothesis by the Knudson. Then talking about the various monoamines, neurotransmitters, pathways, tracts, coming to the nodes, hubs, networks, so on and so forth. So as it progresses, the precision psychiatry evolved, and with a lifetime prevalence of the bipolar disorder of more than 2%, and among the one of the leading cause of the disability and the morbidity, it holds true for the importance of the precision psychiatry staging 2.0 of bipolar disorder. And as it is called, that the right treatment for the right person at the right time is the personalized approach. So in our goal should be treatment of from the patienthood to bring the patient to the personhood and ultimately evolving to the human excellence. Although the psychiatry has not yet reached at the level of precision, we are on the way, and the technological advancements are there, the gadgets are available, and we are evolving very fast with the decade of the neuroscience is evolving, and we are expecting a paradigm shift of the changes in the management thanks to the precision psychiatry. So incorporating precision medicine to clinical practice is a priority, and as described already, that the precision medicine initiative launched by the President Obama, and it highlights its timeliness and the relevance of this concept, and the initiative aims to bring the medicine in a new era of changing our concept. So traditionally, what is to be taught, what is the person-centric model, the holistic model of conceptualization and the management, starting from the genomics and other omics, and we can go for the various potential etiological basis to trace the etiology and selecting appropriate treatment options like large-scale genome-wide association studies with the various genetic factors like the ankyrin 3 gene, ankyrin G, bipolar associated single nucleotide polymorphism, loss of function, split site of the SNPs, the various common final metabolizing pathway. So these are the concepts that are being evolving. Psychiatry is a specialty that has not yet benefited till date with the advanced diagnostic and therapeutic technology. Even today, know that the organic psychiatry or the psychiatry is basically biological and organic, and it is an integral part of the other clinical specialties. But due to the stigmatization and the early days of the conceptualization, the mind-body dichotomy of the Rene Descartesian policy theory, there had been a constant stigmatization of the psychiatry, and the psychiatry of this generation is really as facing the challenges of the evolving conceptualization and clear understanding of the current therapeutic processes with the current diagnostic processes that are being in our hand. We can tell that our future generation will evolve with a more straightforward and more clear-cut thinking process and the transparent conceptualization of the therapeutic process and understanding of various psychiatric disorders. So the vision of the precious medicine is applied as psychiatry as a precision psychiatry promises to be even more transformative than the other fields of the medicine. As mentioned, it's a big data, and the emerging field, big data analytics, provide the means to move beyond the evidence-based group. So we are gaining the data, and the data are getting a very, very faster rate with a supercomputer. We initially thought the whole genome sequence will take around 25 years down the lane, but we have managed to get the whole genome analysis much earlier than that. And the big data in a broad term used to denote the volume of the large and complex measurements. So it is not all about the amount of data you are having, amount of the complexity it's having. It's also the velocity at which data is being created. So with the widespread availability of the internet sources and the artificial intelligence, the data are evolving and at the faster rates that data are generating, and the algorithmic approach with the various computational, mathematical, and statistical algorithm, we can set a new target for the therapy, and this precision medicine is all about this targeted approach. So just going through the artificial intelligence, we all know there's a range of the techniques coming from the artificial intelligence used to identify the patterns of interaction among the variables has been developed over the last few decades. So in these last decades, there has been significant change with the conceptualization of the artificial intelligence, and the big data, the big data-driven conceptualizations are now in our hand. So as with the concept of AI really solidified the previous concept, these fast computers that we all know that were not making any decision by their own. The father of AI, the John McCarthy, coined the term AI, and the Alan Turing developed the Turing test in 1950. The Turing test, we know that it's an imitation game where an interrogator has to find whether the response is generated from the human or it from the computer. So it's almost it's akin to the when we try to fill some form in the booking in the IRCTC website that I am not a robot. So this kind of first artificial application of the artificial intelligence was down the almost in the 60 years back. In the Turing test, we have seen this. Now, with the artificial intelligence is now being widely applied in the management of psychiatry. And in this study, examine the AI's ability to distinguish between individual who had suicidal ideation versus a control group. So analysis of the big data has been employed in the realm of the various other subjects like the economics, business, and politics. And big data analytics and machine learning processes are gaining traction in the health science. And this machine learning has changed the conceptualization of this AI altogether. The machine learning algorithms are able to distinguish between the two groups, that which one is going to predictability of committing suicide is with an accuracy of around 91%. The machine learning algorithm initially analyzing a training data set to establish a model able to distinguish individual subjects across the groups. And once it is complete, the model can be applied to the new data set. So the traditional strength of the human intelligence include a formidable ability to recognize patterns. We know that has been divided as a fluid intelligence and the crystallized intelligence. The massive parallelism and self-organizing nature of the human brain is an ideal architecture for recognizing various patterns that are based on the subtle and invariant properties. And the key capability of the human intelligence is the ability to create a mental modes of reality and to conduct the mental what if experience. And what if experience is very akin that we have various psychological phenomenon like deja vu phenomenon is kind of what if experience. The compared with the traditional statistical methods that provide average group level results, machine learning algorithm, and it holds very true and important perspective while treating the precision medicine in the management of the bipolar disorder. Machine learning can handle large amount of data from multiple biological level, and although impressive in many respects, the brain suffer from severe limitation. We have to consider those facts like we use the massive parallelism that is 100 trillion interneuronal connections are there, and we have to go for this rapid computation. And as we know, there will be we need in our smartphone, the RAM of the smartphone needs to be higher so that our smartphone doesn't get hanged. Similarly, our physiological bandwidth for processing new information is extremely limited compared to the exponential growth of the overall human knowledge base and information. So this is the kind of machine learning. It's a simplified version. It can be unsupervised learning or supervised learning. And the unsupervised can be of various types like clustering and dimensional reduction. In the dimensional, we conveniently use the principal component analysis and linear discriminant analysis model, the two important statistical model we advocate here. And in the supervised learning, the regression model, the decision tree approach, linear regression, and logistic regression. In the decision tree approach, for example, if there are 52 items in a scale, so each 52 items will go for the multiple chi-square test, and it will found that which chi-square significance level is much higher. So higher the p-value, the more p-value is less than 0.001. In that cases, the two factors will come close together, and it will form the own machine algorithm. So this is the supervised learning process. So it holds very, very important, plays an important role for the decision making in the machine algorithm in the management of the bipolar disorder in the precision psychiatry. So with this background, machine learning is theoretically being able to model any function. Machine can find complex nonlinear patterns relating to predictors and outcome, as well as it has been successfully applied in wide range of fields in health sciences. Not only it is limited to the psychiatry or neurosciences in particular, it is also being used in the other fields like radiology, neuroimaging. And this is the kind of the layer that just compared analogous to the computer model. Then the computer will have the input, central processing unit, and the output. So input layer, the input 1, 2, and input n. Then they'll be going the multiple processing in the hidden layers. In the hidden layers, if the processing is very fast, then the decision-making approach will come faster. Like here you can see the 4 hidden layers has been drawn, and the output will be a redundant approach which will come in a regression analysis by output layer 1 and output layer n. Now, just for an example, on the left-hand side, you can see the Instagram picture on the patient having bipolar in manic phase. And in the bipolar depressive phase, there is a color filtering. We know that in the Instagram provides the color filtering option. So in the patient is suffering from the depressive phase of the bipolar disorder, then the picture will be much more gloomy. So it is not a new one. In fact, on way back, the Vincent van Gogh has elaborated in this, the depressive phase and the manic phases with the use of the more colors, and the depressive phase looks gloomy with the lesser use of the colors. So one day that it has been run, the Frankenstein movie, we all have seen that, and their conceptualization are there, that one day will come that the technology will surpass our human interaction, and the world will have a generation of idiots. But this has been a debatable quote, because if you search in the Google whether it has been actually quoted by Albert Einstein or not, you'll find that one of the book edited by the Alice Calaprise, it's mentioned that it is not in the ultimate quotable Einstein, that it has not been quoted by Einstein, but the connotation holds very true, that we are getting technology dependent as an alarm, and it's a cautionary note that we have to use the technology judiciously. Now, coming to the various neural and behavioral correlates, we know that neural behavioral correlates plays a very, very important role, and the behavioral and cognitive approaches like the cognitive vulnerabilities, life event, social supports, neurochemical correlates, all plays a very, very, very important role. And The neuroanatomical correlates with a specific neuroanatomical structure like the amygdala, prefrontal cortex, anterior cingulate cortex, hippocampus. There have been volumetric analysis, and the various functional imaging has shown that this particular area can be correlated. Like the depression is highly recurrent disorder, and mania, hypomania, the likelihood of events exerting a causal role in triggering the various mood symptoms. The various recent evidence has been the adult samples has been found that the hopelessness and the helplessness and the worthlessness and depressive things in the bipolar depressive phase that shows the different activation process in the brain, unlike the unipolar depression. So unipolar versus bipolar depression, and there are changes therefore in the neuroimaging have been found quite different. So it is not only the symptomatology and the other factors, the unipolar depression and the bipolar depressions, various neuroimaging has also shown that they are bit different from the unipolar and bipolar. These two are not equal. Now coming to the various neuroanatomical structures, we all know that the neuroimaging studies reveal the multiple abnormalities, the regional cerebral blood flow and the glucose metabolism in the limbic prefrontal cortex, structured in various mood disorder. It is well-known fact. And also the various areas like the anterior cingulate cortex is the region, particularly acts as a monitor. And the anterolateral prefrontal cortex, the orbitofrontal cortex, amygdala, the emotional center. So these are the key areas that has been found to be affected in the bipolar disorders and as well as the unipolar disorder. The overall pattern of these metabolic changes during the depressive phase suggests that the structures implicated by other types of evidence in mediating emotional and stress responses. So during antidepressant drug treatment, some of these neurophysiological abnormalities reverses with the treatment responders, and most of the regions where neurophysiological abnormalities persist and of the mood state that has shown with the various functional neuroimaging. So in addition, the post-mortem findings also supports the same finding as we see in the various functional neuroimaging. Like the studies demonstrated the reduction of the gray matter volume in the part of the orbital, medial prefrontal cortex, striatum, amygdala, with enlargement of the third ventricle. Now, domains related to the precision psychiatry is very simplified in this chart. We can see the various omics in the left-hand side, the proteomics, metabolics, genomics, like that. And with the pan-omics, there have been other factors, and domains is with the omics, neuroimaging, cognition, and the clinical characteristic cover several domains. These domains can be analyzed using systems biology and computational modeling tool. Measurable components are unseen by the unaided eye, along with the pathways between the disease and distal genotype. So this publication by the Fernandez in the BMC Medical in 2017 has created a very energy, and the talks are there, and all over the world has been focusing of this model, that the domains of the various conceptualization and how the precision psychiatry can evolve. And you can see the treatment A response, treatment B response with the different diagnosis and endophenotype, which can eventually lead to the prognosis A and prognosis B. So multiple factors have been simplified in this picture, but actually the thing is not so simple, because of it has only conceptualized with the individual characteristic, molecular biosignature, big data, neural circuit, cognitive neurosciences, environmental factor, and physiological factors. Now, as we all know, the mood disorder can affect up to 1 in 4 individual, and depression in particular leading cause of the disability, and mostly undiagnosed, misdiagnosed. If diagnosed, they are inadequately treated. And also suboptimal depression can lead to self-medication and substance abuse, as already described by my previous speaker. The Larsen has developed this model of the interaction between the affect and relevant environment, with the desired state point, the comparator, and really desires, beliefs, values regarding the optimal state, and gaining the discrepancy and sensitivity. And then coming to the personal affection, then affect regulation mechanism and current mood status and comparator. This goes in a vicious cycle. So attention to affect relevant stimuli in the environment, process to the regulation strategy of the affect person or environmental change. And then the step 3, temperamental affective reactivity. Step 4, attention to or perception of current state, and gradually moving to the ultimate steps of the desire, beliefs, values, and regarding optimal state. Now coming to the pharmacogenomics, my previous paper has already described about the MP chip, and the psychopharmacogenomics in the 2017 conference and of the annual American Psychiatric Association. I have also the privilege to see with this pharmacogenomics concepts, and I have been invited, but unfortunately the cost of this pharmacogenomics is too high to bear. A number of individual top biomarkers are known to be modulated by medications and current clinical use of the treatment depression. And like you can see, the NRG1, PRPS1, CD47s with the response with the lithium. And coming to the various antidepressant, the response is SLC 6A4, DOC10, NRG1, CD47, and with the nutraceutical omega-3 fatty acids. So in this pharmacogenomics, we can go with the various factors and various particular modulating biomarkers that can be traced. And you can see on the left-hand side of the picture the various overlapping areas are there, like CD47, GLS, and HNRN PDLs are the overlapped with the omega-3 fatty acid, antidepressants, and lithium. And in the new repurposed drugs, you can see the various factors like the CD47, FANCF, GLO1, this and the DOC10, GLSC biomarkers, NRG1. So DOC10, GLS, NRG1, PRPS1 are the common biomarker which are valid with the depression and biomarker, and all the SLC 6A4 is the commonest. It's a common biomarker that has been shared with the depression, bipolar, and manic phases. So bipolar disorder and schizophrenia share high levels of polygenic and pleiotropic molecular architecture. And with this, the two disorders have similar types of impairments in cognitive domains with the processing speed, attention, working memory, and executive function. Now, with the lifetime prevalence of around 2%, bipolarism, one of the commonest neuropsychiatric disorder with the leading cause of disability, and the advances of the various medicines and precious medicine in bipolar disorder can show the inadequate nature of the current treatment, as well as the challenges in modeling and the target identifications. Then the lithium and the GSK3 hypothesis. Next is the WNT, GSK3B, beta-catenin signaling pathways, and beta-arrestin 2, AKT, PPE2A, GSK3 signaling pathway, targeting the phospho-CRMP2, targeting inositol monophosphate pathway, and the novel targets are evolving. And this is the discussion is beyond the scope of today's webinar, but in a simple form that we can go with a long-standing hypothesis concerning the mechanism of action of the lithium with the relevant for the management of the bipolar disorder. As you all know, it inhibits the glycogen synthesis kinase GSK3 family, which is a serine threonine protein kinase family group with the two paralogs of the GSK3 alpha and the GSK3 beta. At the biochemical level, lithium has been shown to display the GSK3 kinase activity through competition for the magnesium in the ATP binding site. And on the early cellular pathway implicated the lithium's regulation of the neuroplasticity. Now, the bipolar disorder symptoms contribute to the substantial morbidity and mortality with the persistent functional impairment, including suicide, which is very, very crucial for our therapist perspectives. National and international treatment guidelines recognize the challenges in treating bipolar, particularly the depressive phase of the bipolar illness, and existing mood stabilizers are only effective in reducing depressive symptom in 1/3 of the patient. Preventing recurrence is extremely important for the precision psychiatry in the bipolar disorder because the standard antidepressants have repeatedly failed to show the benefit in randomized trial. Lithium, considered as a gold standard treatment in preventing recurrence, lamotrigine also failed to separate consistently from the placebo. The lamotrigine, olanzapine, fluoxetine combination, quetiapine, and lurasidone, these are the drugs which are available. Recurrence prevention is still challenging in the management of the bipolar depression. Another model is the consumer decision-making model with the evolved MHCA17 Mental Health Care Act. The decision-making has to be individualized. The patient decision-making process has to be respected, and there are stimuli information with the retention, acceptance, comprehension, memory, and the patient's choice with the consumer data available which need recognition, more availability of the information, the pharmacoeconomics factor that all has to be considered, with the environmental influences like the cultural factors, social factor, familial situation, then economic factor, motivation, knowledge, attitude, so on and so forth. These important factors play a very crucial role for the consumer to take the decision of the choice of their therapeutic process. So need a new paradigm as to precision medicine to psychiatry and precision psychiatry, and proper recognition of early stage of disease is indispensable in order to implement strategies and to capable to avoiding or at least delaying the progression into the later stage. As we all know, that if it progresses in the later stage with the neuroprogression and the apoptosis, this will be associated with the marked and permanent disability. The cognitive deficits is a real challenge, and it can up to 60% of the patient with the bipolar disorder show the permanent cognitive deficit, and this pervasive impairment in bipolar disorder indicate that it may be a trait marker linked with the genetic vulnerability. Emotional processing has to be considered. As you all know, the cognitive dysfunction, emotional processing, and the various severely altered in the patient with the bipolar disorder, and theory of mind, atom, and the emotional processing are significantly disrupted in the euthymic bipolar phase, and it impacts on our day-to-day functioning. And euthymic bipolar also show the moderate to severe impairments in a broad range of executive function. Now, with this traditional psychiatric research investigates a given patient group and comparison with the healthy subject, we know that there are a group of differential diagnoses of the bipolar disorder, schizophrenia, anxiety, bipolar depression, autism, and the symptom domains that are crucial for assessment for the therapist are the cognitive impairment, negative, positive symptom, mood disturbance, and reward dissolution. So I'll conclude with next few slides about the cause of illness, the triple model of the altered gene expression, environment, and brain circuit regulation. And instead of relying on the diagnostic category, a given patient can be classified based on the biological and psychological model. AI has such as machine learning can be extended to compare observation in numerous groups. And machine learning algorithms are very important for the support vector machine or the SVM, which can automatically extract unknown patterns of variation. And the metabolomics has already been described with the DNA, RNA, protein, biochemical, and biological phenotypes, with the genetics and the genomics and transcriptomics, proteomics, and metabolics are emerging factors. And the metabolics are defined as a global metabolic profile in a system under a given set of conditions. And the objective of this review for the metabolomics is to comprehensively assess the literature in the mood disorder and schizophrenia. The mass spectrometry is also an evolving concept which focuses on the identification, quantification of the selected metabolites, which is available. Studies shows the metabolomics in the schizophrenia, bipolar, MDD, such a potential area of the investigation in the research, and also the pathophysiology and the response to treatment, as well as the potential biomarker identification can be applied by use of the mass spectroscopy. And as you all know, the role of the metabolomics are multifolded. And you can see here how genes, genomes, transcriptome, proteomes, and metabolomes are eventually considered with the DNA, RNA, proteins, and the various carbohydrate factors like nucleotides, amino acid sequences, lipidomes. So these are a wide group of metabolites which are ultimately conglomerate for the final pathway, final action pathway to selection of the phenotype of the function. So the computation mathematical modeling is coming up with the management of the various psychotic illness and the various statistical model, like the ROC plot we commonly use in the research work these days, the receiver operating characteristic, and going for the linear discriminant analysis, and the various plots are there. So new in the armamentarium are the two molecules, the brexpiprazole and the cariprazine. These are the two molecules that are being evolved. We have gone with the other molecules, so I will not highlight on this molecule. I'll briefly highlight about this. The cariprazine has been got the FDA approval for the acute treatment of the schizophrenia and the acute treatment of the manic or mixed episode. And brexpiprazole has been FDA approved got the nod from the FDA for management of schizophrenia and the depression. And the mechanism of action we all know it's a partial agonist of the D2T3 receptor like cariprazole, and various receptor binding profile has been compared here vis-a-vis with the cariprazole, brexpiprazole, and cariprazine. And we all know that cariprazine 3 RCTs evaluating the cariprazine efficiency has been found 1 positive and 2 negative. Multiple RCTs and meta-analysis investigation cariprazine in schizophrenia and bipolar disorder. So with these two molecules that are evolved with the evolving in the management of the bipolar disorder in the manic phase and depressive phase, I will just conclude with the final take-home message That is, precision psychiatry is attracting increasing attention and getting the recognized parity. One of the goals of the precision psychiatry is to develop the tools that are capable for clinically informed psychiatric diagnostic, and the cognitive, inflammatory, immunological factors are altered in the both bipolar disorder and the schizophrenia, the two common severe mental disorder. This is the publication that we have recently done with the group, the published in the Journal of Effective Psychiatry, Asian Journal of Psychiatry with Sandeep Professor Ajit Awasthi sir. Three of the publications have recently been published on the management of the bipolar disorder. That is known as a Bitcoin study, bipolar disorder comorbidity in India study. Thank you for the patient sharing, and the final quote by the John F. Gate, who discovered the lithium, that I believe the brain, like any other organ, can get sick and it can also heal. Thank you for your patience hearing.
Well, I thank both our speakers for very extremely excellent, exhaustive, and I think erudite presentations. We've had a lot to learn. I'm going straight to the questions. I'm going to direct the questions related to major depression to Dr. Ray and bipolar to Dr. Ranjan. Now, the first question for you, Dr. Ray, is asked by Dr. J. Dinesh, and he asks that can we look at inflammatory markers like interleukins or CRP to predict relapse or treatment response in MDD? And is that also precision-based therapy?
Yes, a very good question. The first thing is concerning CRP. It has been one of the predictors. It's definitely one of the, a biomarker, one of the earliest biomarkers in depression psychopharmacology to differentiate response between SSRIs and nortriptyline. So, this has been one of the, probably the very first therapeutic biomarker that we have had in major depressive disorder. Interleukin 1, yes, may not be as specific, but definitely it is a biomarker across a number of subtypes of depression, as in case of inflammatory depression. And then inflammatory depression can again be because of various causes. There may be an immunological inflammation. There may be an inflammation which can be non-immunologically cytokine mediated, etc., etc.
Yes, sir. Well, Dr. Ranjan, question for you has been by Dr. R.K. Raju, and his question is that in precision-based treatment for bipolar disorder, I mean, we very often see mixed features that come and go. So do you think mixed features affect precision-based treatment in bipolar?
Definitely, and it's very important for the therapeutic perspective because mixed features are very difficult to treat. And if we do not understand the mixed features, which are the core feature of the mixed feature, which is the predominant polarity, and if we treat it wrongly, then there's a high chance the patient will go for the rapid cycling. So mixed feature is very important, and for mixed feature, the algorithmic approach is there with the help of the artificial intelligence, mathematical, computational, and statistical model. We can actually finalize which is the predominant polarity and which needs to be treated first. So there are therapeutic options, and if we just can go with the precision-based psychiatry, then ultimately we can find out whether it's the depressive feature, hypomanic features, or the manic features is there. And if it is associated with the comorbid substance use, then the algorithm will also can find it out. And with the genetic background and the biomarkers and the previous response to the treatment, we can finalize the actual treatment process. And this precision-based psychiatry will aid for preventing relapse as well as minimize the adverse effects.
Well, question for Dr. Ray. Question that has been asked is that while dealing with major depressive disorder in the context of precision psychiatry, we come to a point where there is diagnostic clarity, subtyping, tailor-made treatment using computational approaches, imaging technology, metabolomics, etc., etc. Will this increase the cost of treatment and delay in taking decisions, or it simply neglects the clinical experience of coming to a therapeutic plan?
Yes. Again, a very good question. The basic tenet of precision psychiatry is it cannot do away with traditional psychiatry practice. Precision psychiatry practice has to go side by side with by the traditional psychiatry practice. And the best psychiatric practice or the best psychopharmacological practice is basically a very harmonical manage between the so-called traditional psychopharmacology practice and precision psychiatry. So practicing precision psychiatry doesn't doesn't imply doing away with traditional psychiatric knowledge or skills. It is basically a complement to the traditional psychiatry skills. One, expenses wise, it again depends on various governments. It depends, it's a very difficult question to answer because it depends on government policies. It depends on how your medical insurance is there. For example, precision psychiatry may have some Medicaid. It's a, the insurance may be, better entertained in the West than over here. A lot of people, the insurance agents, etc., have to be introduced to the concept and have to be familiar with the concept of precision psychiatry. So I would not be, it is definitely not going to delay the treatment, but expense wise, it's a difficult question to answer for me.
Right.
May I add one point here, Dr.
Yes,
D'Souza?
yes, please.
Yeah,
Please.
thank you so much. So while considering the treatment approach for our patient, that has to be individualized. And we consider the 4 factors, that is efficacy, tolerability, safety, and the cost factor. So these 4 things has to be considered. Now, delay in treatment is very, very important. The delay in treatment, misdiagnosis, or the wrong diagnosis, we cannot afford that cost. It's just think about 30 years back, we don't have any C-arm to operate. So now we're having C-arm, we can preciously see which operation to be done in which place. So we can now do the catheterization in the cath lab. We can do preciously fix up the pacemaker in the right position. So with the help of the C-arm, the technology is available. But initially it was pretty costly, but with the gradual use on a regular basis, the cost factor will come down. So similarly in the precision psychiatry, all these omics and other factors may seem that it will become very costly, but at the end of the day, it will immensely benefit to our patient and the cost factor will come down.
Okay. Well, this is a question which I think both of you all could answer together if you all have viewpoints on this. And this has been asked by Dr. Arnab Datta, that precision psychiatry is based on disorder, focuses on etiopathogenetic links like inflammatory mediators, etc., in a bottom-up approach. Whereas clinical precision psychiatry focuses on symptoms, personality, nuances, etc., to guide in a top-down approach. Which is a more specific or a better approach in the near future?
I think Debashish should answer first.
I would say there should not, both of them, again, it depends on the concept, the construct of locus, modus, and focus. At that point in time, precision psychiatry doesn't mean you're individualizing the treatment only. It entails that you're not only individualizing the treatment, you are also mapping the treatment. That is how it's, it's differing from personalized psychiatry one. So both the bottom up, it has to be tailored according, you are guided basically by the algorithm, and the algorithm which you have employed in that particular instance, that particular clinical environment, again has to be tested. If that algorithm is inferior to some other algorithm, or if that algorithm is relatively ineffective, we have to switch on to another algorithm.
Yeah. Just to add on this, that the clinical factor and the biomarker, available biomarker, as asked by the Dr. Datta, that the top-down approach by the clinical approach and the bottom-up approach with the biomarker, it is not like that. It's both approaches has to be conglomerated, and it is not that these two are the watertight compartments. So there is intermingling for the clinical decision-making process. It goes hand by hand, and we need to be very that other factors, as mentioned in my presentation, that the age, gender, ethnicity, genetic factor, early upbringing, then gene environment hits, then coming to the neurotransmitter, pathway, tracks, nodes, hubs, networks. So all has to be considered in together. In the machine learning, it's very simple that in the machine learning, you can put the clinical approaches in the one side, when you are formulating any diagnostic criteria for any disease, so where in that case you just write down the clinical features and go with the decision making approach, decision tree approach, by doing the multivariate analysis or the logistic regression approach. Then on the right hand side, with the different biomarker, you can do the similar thing with the machine learning. These two can be compared, and it will find that the which genomic locus is going to be specific for the schizophrenia, which is going to be specific for the bipolar disorder. But still, it is early days. The miles to go that to get the precision psychiatry for the genetic to just have a good communication, direct causal relationship between the genetic factor and the biomarker and the clinical aspects. But still, it shows a good, a very bright prospect, and it holds a great promise in future. The precision psychiatry can match with the clinical approach and the biomarker availability.
Right. Well, I will ask this to you, Ranjan, because this is, I mean, you work in a smaller city. So I'm just asking you from this perspective. Someone has asked that how is the application of precision psychiatry in advanced countries and metro cities different from that in the Indian rural scenario? Because we get practical hindrances when it comes to getting biomarkers and other neuroimaging in rural India, and we depend on all the available resources first. So how can we uplift this scenario to get precision psychiatry there in the future?
Yeah, absolutely. That is a real challenge, especially in our country. But still, it is evolving, and with there are lots of approaches are coming which are not so much costly. So we can use the smartphone technology. In the smartphone, the app can be developed with the genetic loading, and the history can be taken properly. Then with judiciously we can go for the various metabolomics and the other omics study in the tertiary care setup in a government hospital that can be sponsored. So in the firstly, at the outset, the patient has to be tracked. So if there is a genetic history in the family tree, if we find the strong genetic loading is there, then we can just channelize those particular patient for the with the availability of the smartphone application to our junior resident or the senior resident. They can formulate that. They can pick up those high risk groups. So taking this high risk group to the genomic study, we can also genomics and other metabolomic study with the available resources in hand. So I acknowledge that it's still meager, but I think that with the days progressing, we can have the availability from the what is available at a very high cost in the 2017 APA conference that I have noticed that can be a reality in the down the line in the next 3 or 4 years. So I'm very much optimistic.
Okay. We have three more
Yep.
questions.
Yep.
Now this question I would want Dr. Ray and Ranjan both to answer. Where do you think is the role of methods like DBS and ECT, deep brain stimulation and ECT, when it comes to precision psychiatry?
Yeah. ECT, there has been some studies in precision psychiatry in major depressive disorders, which have actually positioned ECT, especially unilateral ECT, uh, with a lot of predictive, not only sensitivity and reliability, but also with accuracy. And ECT has been found to be beneficial in a heterogeneous, so-called heterogeneous, when we are speaking phenotypically, but concerning precision psychiatry in a population which has been actually delineated as a population which would definitely benefit from ECT. There has been almost like a sort of an earmarking of this population. One.
Oh.
Yeah, if we just compare the biological treatments like deep brain stimulation, ECT, and the RTMS vis-a-vis. So among these, application of the RTMS is much easier, but RTMS lacks specificity. So you have to put the coil in a particular place. The ECT is ranks in between that, but the application of the ECT is very much limited, especially after the MHCA 17. The psychiatrists are not using it so much, and the availability of the anesthetist is a key issue. But ECT could be more specific, but the deep brain stimulation is highly specific. But the deep brain stimulation is an invasive approach, and it requires certain precaution. But with initially, if you're going through the functional neuroimaging, we can pinpoint the location which of the areas can be stimulated, which are not activated. So in this case, particularly in the depressive phase, you will feel the underactivity of the anterior cingulate cortex. So by precision psychiatry, we can find out the particular areas or zone that needs to be stimulated, and by deep field stimulation, we can preciously, accurately do that. But still, the use is limited, especially in the smaller cities, as we already mentioned, Dr. D'Souza.
Right.
Can I add
Well,
something?
yes, please.
Uh, as far as I am aware, there has been no study in precision psychiatry on the use of either deep brain stimulation or RTMS, whereas ECT has at least a couple of studies in both major depressive disorder and bipolar disorder, as far as precision psychiatry is concerned.
Right. This is now both of your moment of glory. Dr. E. Mohan Das has written in and said that both of you all have presented excellently. So that's the first moment of glory for both of you.
Thank you
And
so
then
much.
then he has said that a new division of psychiatry, probably psychoradiology, in the connectomics area is coming up, where a psychiatrist will have to learn computers in detail. But I wonder whether this can be translated in India. What do you all feel?
Yeah, the question is whether is it a question of can be, or is it it should be. I believe that all of us have to update ourselves, and machine learning is not so far when it's going to be a part and parcel of our everyday practice, and concerning a question which you had asked about the availability and the logistics of precision psychiatry in faraway areas where you have an economic hassle, when you have a logistical problem, why don't you use clinical phenotypes which have been laid down very clearly, both in all the mood disorders, and not only in mood disorders, even in schizophrenia, in precision psychiatry. And so precision psychiatry is not only laboratory, not only machine learning, it also has a lot of these clinical phenotypical constructs which we have been using already, albeit unknowingly, in our traditional psychiatry practice. We can still use that more consciously towards a sort of a more relatively precision psychiatry approach in places where we have logistical hassles.
Yes.
Yes. Just to add on this, that in the early phase of in the undergraduate and postgraduate teaching in our days, there had been only EEG available and the structural imaging CT scan. Then, as it evolved with the EEG, we have found that the QEEG, then the analog to digital version, then coming to the evoked potential P50, P300, structural to functional evolution with the availability of the PET scan, SPECT scan, fMRI. Then we have come across the voxel-based morphometry. Then gradually we are getting much more closer. So it doesn't make any sense that the psychiatrists who are using the smartphone so regularly cannot use these newer technologies to help to aid them for the diagnosis of the various newer imaging techniques. It's a rule, rather it's going to be a custom and the rule in the coming days. And I have seen that most, with due respect to my radiologist colleague, and most of this imaging are being done by the technologies. So it is just a learning process. If you just go and learn it, it will become very easy. And it is at most required, as mentioned by Professor E. Mohan Das said, that the psychiatrist should run radiology. It should be a compulsory training like the neurology training is required with the psychiatry. Radiology training is at most required with the availability of the newer gadgets and the newer technologies.
Right. I would like to at this point say a big thank you to both our speakers, because that brings us to the end of our questions. I think with precision psychiatry coming in, we are definitely going to not only improve patient care, improve also our clinical skills, and provide customized, individualized, effective treatments to our patients. So I think it's definitely going to be something which we're going to look forward to. It's now my proud privilege to announce the winner of the 5,000 rupee Amazon voucher. And I think that goes to Dr. Arnab Datta for his question, particularly about the clinical precision versus biomarker precision. What is better? So I think that's where that's there. And I think Akansha will share the slide. Yes. So yeah, so that's the question. Now, so that brings us to the end of today's program. I thank both our speakers for their extremely excellent presentations and their time taken out on a busy Tuesday evening to be here. And that brings us to the end of the program. And on behalf of Banai and everyone here, God bless you and good night.
Thank you so much, Dr.
Bye.
Disria.
Good
Thank you, Dr. Roy. All the team who have in the Banai and Professor E. Mohandas and Dr. Anutan Mintal, sir. Thank you so much.
Thank you. Thank you.